Okay, so chest X-ray. Okay. This is very important. So different tissues in the body absorb X-rays at different extent. So some has bone has high absorption, so it appears white. Other tissue somewhere in the middle absorption appears grey in color. Air has low absorption, it is black in color. Okay. So this lungs contains air, it is black in color. Heart is soft tissue, so it is almost grey in color. And in the middle you can see the vertebral column. These are bones and other these ribs, clavicle, scapula you can see. These are white in color. Okay. So these are the densities in the X-rays. 4 densities in X-rays. Black air or gas appears black. Dark grey fat appears dark grey. Light grey appears fluid or solid organs, and white appears the bone or calcium. So from air to bone, it is increasing opacification, increasing whiteness. Okay. এই শোন অবিনাশকে ডেকে দিস তো অবিনাশকে ডেকে দিস Okay, so chest X-ray PA view versus SEPI view. What is PA view? We have already discussed during superior X-ray. Postero-Anterior view, IP is Antero-Posterior. This represents the direction of flow of X-ray. Here from posterior to anterior, anteriorly the plate is kept, and in AP view from anterior to posterior X-ray is passing, and posteriorly the plate is kept. Okay. So PA view, the X-ray penetrates through the back of the patient onto the field. And AP view, the X-rays penetrate through the front of the patient onto the field. And in lateral view, the X-rays penetrate from one side, left or right side of the body, and film is kept on the opposite side. Okay. So this is chest X-ray, how it is taken. Okay. And the arms are placed like this for proper exposure of the chest. So chest X-ray, you have to understand, always check the name and date when it is done. Check the orientation, right and left is level somewhere in the X-ray plate. Okay. Projection, it is PA or AP or lateral view or in which decubitus it has been taken. Supine position, accurate assessment of heart size and mediastinum can be done only in the PA view. Okay. In bedridden patients, generally AP view is done. So there you cannot assess about the heart size and mediastinum in chest X-ray. Okay. All the supine or portable X-rays are AP view. Bedside X-rays those done. These are AP views X-ray. So you have to look for this A, B, C, D, E. Okay, for in the X-rays. A is airway for both in Antero-Posterior PA view and in lateral view. In both view, we have to note all these structures. First, A is the airways. Bones, ribs, vertebra, two humerus, clavicles, scapula. You note these bones for any fractures or any lytic or black lesions over the bones occurs in some disease conditions. Sclerotic or white plaques formed over the bones. Vertebral body heights also you have to note. Next is cardiac vessels. C is circulation. Circulation means cardiac shadow and different great vessels you can see in this chest X-ray. Cardiac silhouette and mediastinal contours and width. And you also note the hilum of the lung. Normal hilar shadow is made up of vessels. Left is higher than the right by about 2.0 to 2.5 centimeter and must have a concave shape. And pulmonary vessels, upper zone vessels are smaller than the lower zone. So next D is the diaphragm. Look under the diaphragm, free gas shadows on the left side. Free gas shadows, normally fundic gas shadow is visible under the left dome of diaphragm because of presence of the stomach. And free gas shadows are present in perforated viscus in the abdominal cavity. Okay. And costophrenic angle for pleural effusion. It is obliterated in the pleural effusion. Next, you see the extremities, the corners of the field, the line position and hidden areas like lungs, epices, Behind the heart, breast shadows, paravertebral areas and thyroid. These areas you have to see. Okay. See, this is a chest X-ray looks like, and what are the structures? You remember this picture very carefully. All this can be given in your OSCE. You have to identify the structure and related questions will be asked. Okay. So here is the tracheal shadow. This black color shadow is the tracheal shadow. And these white dots, you can see these are the spinal processes of the vertebra. On the two sides, these are the clavicle, here is the scapula, these are the shadows of the rib, here are the lung shadows, okay. And here this is right border of the heart, left border of the heart, two domes of the diaphragm, right and left dome. Below the left dome, here is the gastric air bubble, okay. Gastric gas Fundy gas shadow is here, okay. And here these angles you can see, this is costophrenic angle formed between the ribs and the diaphragm, and this is cardiophrenic angle formed between the heart and the diaphragm. You can name from the structures it is formed by. Next, you have to know what are the structures forming the right border of the heart and what are the structures forming left border of the heart. So, right border of the heart is formed from above downward by the brachiocephalic vein, then superior vena cava, okay, then right atrium. Mainly these structures will form the right border, and in the most lower part inferior vena cava. And on the left side there is aortic knuckle or aortic knob. Okay, this is formed by arch of aorta. Here is the left atrium. Here is the left auricle. Left auricle will be above, then left atrium, and then left ventricle. Okay, apex of the heart is formed by the left ventricle. Okay, so all these structures you have to note. And see these white markings you can see, these are the bronchovascular markings, okay. These are the shadows of the blood vessels within the lung parenchyma or near the hilum. So see here tracheal shadow on the left border of the heart, aortic knuckle. Here you can see some branches of pulmonary artery, bronchovascular markings mainly, atrial appendage, and here is the left ventricle. Okay. On the right side, you will see the brachiocephalic vein, then superior vena cava, right atrium, and these are the bronchovascular marking formed by branches of the pulmonary artery and bronchial artery. These are the diaphragms. Okay. And this is lateral view of the chest. Here you can see the aortic arch, ascending aorta, pulmonary artery. Here is the heart shadow. Here is right ventricle. This is dome of the diaphragm. Left ventricle, some part of the left ventricle. Here is the thoracic vertebral column. This in front of the vertebral column, here is the descending aorta. Then this body of vertebra, in between the vertebral body, the black lines are the intervertebral disc, and anteriorly you can see the sternum. Also you have to see, note the different mediastinum, superior, anterior medial and posterior mediastinum. Lateral view, see here ascending aorta, arch of aorta, descending thoracic aorta, vertebral bodies, intervertebral disc. Here is the right ventricle, left atrium, pulmonary artery. Okay. Here is the costophrenic angle. So these are the lung shadows and different lobes. Upper, middle and lower lobe of the right lung, upper and lower lobe of the left lung, and in between these two here is the heart shadow, and these are the domes of the diaphragm. Lateral view, three lobes of the right lung have been shown, upper, middle and lower lobe. Okay, and this is the heart shadow you can see. Okay, understood? So these structures you have to see. Carina, carina means bifurcation, tracheal bifurcation, tracheal shadow, aortic knuckle, clavicle, rib shadows, heart shadow, pulmonary artery, diaphragm, stomach, fundy gas shadow, costophrenic angle, cardiophrenic angle, here below the right dome, liver, shadow of liver. Here are the near the hilum of the lung, bronchovascular markings formed by pulmonary artery, lung shadow, scapula, all these you have to see. Okay. So what is penetration? Penetration of X-ray have to be proper. Low penetration is also not good. High penetration is also not good. Okay. So you have to be able to see the ribs through the heart. Rib shadows you will see. Okay. Barely see the spine through the heart. Vertebral column is barely seen. Only the spine can be seen near the tracheal shadow. And pulmonary vessels can be traced nearly to the edge of the lungs. Underpenetrated films. Here, X-ray penetration is not proper. Okay, hemidiaphragms are obscured. You cannot see the angles. Postophrenic, cardiophrenic angles cannot see properly. Rib shadows are not that much prominent, and pulmonary markings are more prominent than the actual. Okay. Overpenetrated field, see lungs are more black. Lung feels darker than normal, may obscure the subtle pathology. You can miss the pathology in underpenetrated or overpenetrated field. And see the spine well beyond the diaphragm. You can see the spine can be seen. Heart shadow is not properly visible. Okay. And inadequate lung details. Bronchovascular markings are also not prominent. Next, we have to know the positioning or rotation. Does the thoracic spine align in the center of the sternum and between the clavicle? This is proper positioning. And clavicles are equidistant from the spine. Okay. So, this is spine to clavicles are equidistant from the spine. Okay. This is black lung. First, black lung occurs if the rotation is not proper. Okay. First, consider the rotation. Look for the clavicles. If clavicles are located in proper position or not, the lung closer to the fin plate will absorb more of the X-rays and so will be whiter. While the lung further away allows distance for scattered rays to get through and so will be blacker in color. Okay. And right and left can be determined only from the written L or R. Okay, L is left, R is right. And you can see the gastric bubble should be seen on the left side. Only if there is dextro rotation, then only there will be change. Okay, apex of the heart, gastric bubble, you can see on the left side. That's how you determine right and left. And look for the soft tissue structures if there is any abnormality in the soft tissue structure or in the bony case, and check for the symmetry, deformities, fracture, muscles, calcification and any lytic lesions. Look at the diaphragms, domes of the diaphragm. There is tenting in case of some pathologies of the diaphragm or paralysis of diaphragm. There may be tenting or free air under the diaphragm, that means perforation. Okay. Abnormal elevation can be there in case of paralysis of diaphragm, and margins should be sharp. The domes have a clear outline. The right hemidiaphragm is usually slightly higher than the left because of the position of the liver. Okay. And for heart shadow, you have to see the size, shape, and seal out margins should be sharp. Two margins, right and left margins of the heart should be sharp, and diameter of the heart shadow should be half of the thoracic diameter. Okay, so cardiothoracic ratio should be 1:2. Okay, and AP views make the heart appear larger than the actual. That's why you cannot determine the size in AP view. Cardiovascular markings, it is due to heart and great vessels has a right and left border. So these are the two borders of the heart. Right border is venous border. Okay, and it is formed from above downwards by the right brachiocephalic vein. Here, right brachiocephalic vein, then superior vena cava, then right atrium, inferior vena cava. A left border is formed from above downward, left subclavian artery, arch of aorta or aortic knuckle, auricle of the left atrium, and the left ventricle. It forms most of the left border of the cardiac shadow, and the cardiac shadow will be according to the shape of the heart. Okay. This slide is very important. What are the structures for my right border? What are the structures for my left border? You must remember. Next, cardiothoracic ratio is asked. Very important. It is less than 50% in adults. PA film, AP film magnifies the heart. In AP film, heart shadow will be larger. And causes of increased cardiothoracic ratio, it occurs in obesity, pectus carinatus, portable film, AP cardiomegaly, pericardial effusion. And you have to note the shape of the heart. Okay, and note for any valve calcification. The deep white dot will be present in case of valve calcification. Okay. See the venous, this is the venous sided structure. Well, this is the arterial side, left side. So see here, this is the brachiocephalic vein. Okay, then superior vena cava, then right atrium, inferior vena cava. On this side, here will be the left subclavian artery, then aortic knuckle, pulmonary trunk. Here is the left auricle, and here is the left ventricle. Okay, and you match this from here, and these are the bronchovascular markings near the hilum of the lung. And two domes of the diaphragm you compare. Right dome is slightly higher than the left dome, and below the left dome here is the funding gas sac. Okay. So what will be the change in pericardial effusion? Pericardial effusion, there will be cardiomegaly with no particular chamber enlargement. There will be money bag or leather bottle or flask shaped heart. Okay, this will be the heart shadow. Heart shadow is increased. Cardiothoracic ratio has changed. Okay, and with relatively clear lung fields. Lung fields are more clear. Bronchovascular markings are absent sometimes. Oreo cookie sign on lateral chest X-ray. Oreo cookie sign, this represents the cream, and on the two side do cookies. Okay, so this term is important. Leather bottle heart or flask shaped heart, money bag heart is seen in this condition, pericardial effusion. Okay, these are important for your MCQs. Oreo cookie sign, all these terms are used. And most sensitive investigation for diagnosis is echocardiography. Okay, 15 ml can be detected in echocardiography, more than 15 ml. And some amount of fluid is normally present in the pericardial cavity. If it is more than 15 ml, then only you consider as pericardial effusion. And this is pacemaker, chest X-ray with pacemaker. It will be visualized like this. Next, two angles. These two angles are very important, very frequently given in your OSCE. Margins of the angles should be sharp. Two angles are there: costophrenic angle, cardiophrenic angle. Costophrenic angles are right and left and are formed where the domes are covered by the diaphragmatic pleura and meet the lateral wall of the thorax. Here is the costophrenic angle. And cardiophrenic angle, they are also right and left and formed where the domes covered by the diaphragmatic pleura meet the right and left border of the cardiac shadow. Here is the two cardiophrenic angles, right and left. Okay. And for the lungs, you have to note whether the lungs are too black or too white. Too white means it is opacity is present, or some density, or some infiltrate, or some mass or nodule is present. Alveolar air cells, you have to see, normally contain air, so appear black. And alveolar cells, you can see in infection and inflammation, there will be accumulation of pus in the alveoli, in tumor formation, and eosinophils in allergic conditions. Fluid accumulation occurs in aspiration, in drowning, edema, hemorrhage, like this. Okay, and interstitial changes occur in some disease conditions, and you have to know the differentiation between collapse of lung and consolidation. Okay, and lung volume loss, it will lead to lung volume loss. There will be shifting, mediastinal shifting, and fissures are shifted. Domes of diaphragm can also change. And hilum, we have to note the hilum and rib crowding occurs in collapse of lung or over distension of the lung in emphysema. Okay. And air bronchograms. Air bronchograms are bronchovascular markings formed due to the vascular shadows, the different branches of pulmonary artery, bronchial arteries, and different veins. See, these are the lung fields. You can see normal lung field, and these are white shadows are the bronchovascular markings, and they are more prominent near the hilum of the lung. So, lung fields you have to see for infiltrates, increased interstitial markings, masses, absence of normal margins, air bronchograms, and increased vascularity. Next, consolidation. So that was normal lung shadows. Okay. Next, we are going to some abnormalities. First, consolidation. So in this part you can see the consolidation occurring in the upper lobe of the right lung. So density in the right upper lung field, lower density, loss of ascending aorta seal out. Okay, ascending aorta cannot be visualized properly. No shifting of mediastinum has been seen. Tracheal shadow is in midline, and transverse speeds are not significantly shifted. Okay, this is transverse feature of the lung, not seen, and air bronchograms are lesser. So see here consolidations have been occurring near the hilum. Okay. Silhouette sign, when air in the alveoli replaced with fluid or cells, and contrast between the lung and the neighboring structure like heart, diaphragm is lost and borders become indistinct. That is known as silhouette sign. And use the silhouette sign to determine which lobe of the lung consolidation has occurred. Next, we are seeing collapse lung. See, on this side, normal bronchovascular markings you are seeing. On this side, it appears complete black. No bronchovascular marking has been shown. So here on this side, lung has collapsed and it is lying like this. The small area is the lung. Lung has collapsed and pleural cavity is extended like this. There is no bronchovascular marking. That's how you identify lung collapse. Okay. And here, in case of collapse, generally there is mediastinal shifting. This tracheal shadow you have to see for any shifting. Next, pulmonary edema in these areas. It is not, whole of the area is not white. Some white areas, patchy white areas. Okay. So that's how represent the pulmonary edema. Here also in all two, both the lobes are involved. Okay, pulmonary edema. Next is lung abscess. This is the abscess cavity. Some pus or some collection is there, and this part is air. Okay, so this is lung abscess involving the middle lobe only, middle lobe of the right lung. Hydatid cyst, water lily appearance in chest X-ray in content rupture of hydatid cyst. Okay, this is the cyst cavity. It's air. This is the fluid level, and over the fluid level, some water lily appearance will be there. Okay, in hydatid cyst. These terms are important. Okay, water lily sign in hydatid cyst, chest X-ray. Next, pleural effusion, very frequently given abnormal X-ray. Fluid accumulation in the pleural space. Radiological criteria will be increased density, independent position, and claustrophrenic angle in the PA view, along sides in lateral decubitus position, and along posteriorly. The fluid will accumulate in the dependent position. In standing position, it will obliterate the claustrophrenic angles and also sometimes cardiophrenic angles. And along sides in lateral decubitus position. Patient is lying in lateral position, then it will occupy the on this lateral side, which is lower in position. And if patient is lying in supine position, it will occupy the posterior pleural spaces. Okay. giving diffuse haziness on the side of effusion. And blunting of the costophrenic angle, lack of identifiable diaphragm. Seal out sign is positive. This is pneumothorax. Okay. On this side, air accumulation have occurred and it has pushed the lung inside. So this part is having the lung. Next, hilar enlargement. Some hilar enlargements are seen here, and it can be unilateral or bilateral. Look for any convex contour, and what are the causes? It may occur due to some neoplasm like central bronchogenic tumor itself and lymphadenopathy, CA bronchus, lymphoma, lymphangitis carcinomatosis, or infective cause like infection, TB infection, mycoplasma, viral infection in children, or sarcoidosis, usually unilateral and very symmetrical, and post-stenotic dilatation of the pulmonary artery. It also causes hilar enlargement, and pulmonary artery aneurysm. This is very rare, and all causes of pulmonary arterial hypertension, primary idiopathic cause or secondary cause. Okay, and long-term pulmonary embolism, chronic left to right cardiac shunt. All these are cause of this hilar enlargement. Next are Carles lines. Three types of lines are there: Carles A lines, Carles B lines, and Carles C lines. This you will learn during medicine. Bat wing appearance. Okay. Bronchovascular markings are very prominent. Okay. Hilar enlargement. Next, you have to see pleural plaques. Over the pleura, there is formation of white plaques. Okay, it occurs in asbestosis. Thickening of the parietal pleura, which calcifies, especially seen over the diaphragmatic surface as dense linear bands, and does not equal asbestosis, which pulmonary parenchymal disease related to asbestos exposure can occur together. Okay. Next is pulmonary embolism. Okay, more often it appears normal or segmental or subsegmental linear atelectasis. Some part there will be collapse of the lung. Atelectasis also means collapse in the some part of the lung. There is focal region of hyperlucency, oligemia, western mouth sign, black area of lung seen only 2%, and peripheral foci of consolidation or infarction, that is known as Hampton's hump, less than 10% shows infarction, and dilated central arteries due to arterial hypertension, and abrupt cutoff of a vessel only if in the central arteries occurs, and pleural effusion occurs in this pulmonary embolism. Next is cannonball appearance, rounded ball-like structures in the lung saddles. This is very important, occurs in carcinoma. Always suspect carcinoma in cannonball metastasis. Okay. So osteogenic sarcoma, thyroid follicular carcinoma, testicular carcinoma, choriocarcinoma, CA prostate, malignant melanoma, some GI, some very advanced nasopharyngeal and pharyngeal carcinomas, CA breast, and lymphangitis carcinomatosis. All these cases cannonball metastasis can occur. So all are carcinomatous conditions. Okay. And in known malignancy, these are the cannonball mets. You can see this epi view, PA view, and this is lateral view. These are the metastatic areas. And you have to see the mediastinum structures also. 4 T's you have to see in the anterior mediastinum: thymoma, thyroid goiter, teratoma, terrible lymphoma. Okay, generally in this occupies almost 30% of the width of the thorax. But if it is more than 30%, then you have to suspect any abnormalities. Okay, these 4 you must consider. Next, in chest X-ray, in barium solo X-ray, you can visualize the esophagus in the chest X-ray. Okay, esophagus we will discuss generally during the abdomen barium, and contrast material used here is the Barium sulfate mixed with water to form a 50% suspension. Patient is asked to drink the solution and then you will take the X-ray. Okay, at some intervals, 1 minute, 5 minutes, 3 minutes, like this. At some interval, you have to take the X-ray. Here, look. And contrast material. Patient drinks this substance and then you will take the X-ray. Okay. Esophagus is visualized. Normal esophagus is visualized like this. Barium swallow X-ray. And normal AP view, lateral view, the tracheal shadow, you can see AP view, lateral view. Okay, and this is with barium swallow. Here is the position of esophagus. Here is the position in lateral view. So when you will do barium swallow X-ray in dysphagia, heartburn, retrosternal pain, regurgitation, odynophagia, pain during deglutition, hiatus hernia, reflux esophagitis, stricture formation, esophageal carcinoma, and motility disorders like achalasia cardia. Lower end of esophagus, the sphincter is closed. Okay, so there will be abnormal dilatation with the lower part of the esophagus, that is known as achalasia cardia. And diffuse esophageal spasm. Here you will see corkscrew-like appearance of the esophagus. And pressure or infection from extrinsic lesions. An assessment of any abnormality like pharyngoesophageal junction including different diverticulum, Jenker's diverticulum, cricoid waves, cricopharyngeal achalasia. Okay, thank you. Regurgitations, foods are coming out from stomach to the esophagus. Normally, food going downward. If it comes out, then it is regurgitation. Odynophagia means pain during deglutition. If you are eating something and feeling pain in the esophagus, then to identify the cause, you have to do barium swallow. Retrosternal pain, just beneath the sternum, chest pain হবে এখানে, heartburn, ওটা due to reflux, gastroesophageal reflux, একসঙ্গেই আছে generally. Okay, শুধু এক্সরে গুলো দেখে রাখবে, এটা right anterior oblique view, esophagus carcinoma, there is abnormal dilatation and here is one mass formation. Mass formation will lead to filling defect. Okay, like this. This is carcinoma esophagus. Here is the mass. And this is corkscrew esophagus, diffuse esophageal spasm. It will appear like a corkscrew. Okay. Here, corkscrew esophagus. Achalasia cardia, abnormal dilatation of the esophagus and lower at a rat tail appearance. This is the sphincter, cardiac sphincter is closed almost. Stricture formation, this part is dilated and here is the stricture of the esophagus. And Jenker's diverticulum will appear like this. Okay, the pouch-like formation from the posterior aspect of esophagus. Jenker's hiatus hernia. Here is this fundus of the stomach. It enters into the thoracic cavity through the opening. Okay, that is hiatus hernia. Esophageal varices will look like this. Filling defect. Okay, filling defect will be there. Esophageal varices of. And tracheoesophageal fistula. Fistula appears like this. Here is the tracheal shadow, esophageal shadow. They are connected through a transverse channel. And here is another part of the fistula's tract is visible. And here is one ulcer, deep esophageal ulcer. Okay, that color shadow you can see. This tracheal shadow. And these are the vertebral spines of the vertebra. Here is the clavicle, sternal end, acromial end. This is the scapula. These are the rib shadows. Okay, posterior rib shadows. And these are the anterior rib shadows. Okay, so you have to identify. And these are the bronchovascular mark things in the lung shadow. And here is the first rib. Above this, here is the apex of the lung. Okay. and this is heart shadow. This is right border of the heart, left border of the heart. Okay, so right border of the heart formed by the right brachiocephalic vein, superior vena cava, and right atrium, here inferior vena cava. Left border of the heart formed by the here is left aortic knuckle, left, aortic knuckle. Then there will be auricle, left auricle. Here is the left ventricle. And these are the domes of the diaphragm, right and left dome. এগুলো হচ্ছে fundic gas shadow in the stomach. Okay, and this angle is the key angle. বল এটা postophrenic angle, and here these two angles are cardiophrenic angle. Okay, so this is complete, and these are the soft tissue shadows, skin, subcutaneous tissue, other tissues, and in female you also can see breast shadow. Okay, and here you can see the breast shadows.
এটা anterior posterior টা
যা লেখা থাকবে তাই PAVU লেখা আছে PAVU.
posterior
You have to know the also the male patient, female patient, age of the patient, right and left is written. Okay, it is actually female patient, breast shadows are there. This is the vertebral bodies. Okay, এটা বোধহয় APVU কি না এটা PAVU. Okay, so vertebral bodies, the spines, tracheal shadow, clavicle, scapula, rib shadows, bronchovascular markings, heart shadows. Okay, and you can see right dome is higher than the left dome. A fundic gas shadow, markings are there. So lung e kono collapse nei. Okay, and this on the right side, here is the right border ki form kore bol from above downward. Right brachiocephalic vein, superior vena cava, right atrium, inferior vena cava. The left side, aortic knuckle, left auricle, left ventricle. So this is the right border, left border of the heart, এটা aortic knuckle. আর এখানে মেনলি ওই ডোম অফ দ্য ডায়াফ্রাম দেখানো হয়েছে, clavicle সেম, বাকি সেম। এখানে ট্র্যাকিয়াল শ্যাডো, স্পাইন গুলো প্রমিনেন্ট আছে, যে কোনো একটা দেবে। ওকে, আর এটা ফ্রি গ্যাস আন্ডার দ্য ডায়াফ্রামও হতে পারে। ইন হুইচ পজিশন, ইন হুইচ ডিজিজ কন্ডিশন ইউ উইল বি আস্কড in case of perforation of free gas under the diaphragm. Okay, আর পারফোরেশন হলে কি করতে হবে, পেশেন্ট তো কোমা শকে চলে যাবে, ইউ হ্যাভ টু ডু ল্যাপারোটমি করে সব রিপেয়ার করতে হবে। এটা অ্যাঙ্গেল postophrenic angle, these have been given in exam already, and this bronchovascular markings. এখানে the cardiothoracic ratio is more, maybe hypertrophy is present, কিন্তু কার্ডিওথোরাকিক রেশিও বেশি, বাট হার্টের অ্যাপিয়ারেন্স কিন্তু ওরকম নয়, ওই বটল শেপেড হার্ট ওরকম নয়। ওরকম থাকলে তখন বলতে হবে পেরিকার্ডিয়াল এফিউশন। ওকে, এটা পেরিকার্ডিয়াল এফিউশন নয়, কোনো কারণে হাইপারট্রফি আছে। ওকে, এটা তো ট্র্যাকিয়াল শ্যাডো, বাকি তো সেম আগের মতনই, এখানেও সেম ওটাই দেওয়া আছে, যে postophrenic অ্যাঙ্গেল দেওয়া আছে, ডোমস অফ দ্য ডায়াফ্রাম, ফান্ডিক গ্যাস শ্যাডো, হার্ট শ্যাডো, এটা সবগুলো ভালো আছে। দেখ, রাইট বর্ডার, লেফট হার্টিক নাকেল, অরিকেল, লেফট ভেন্ট্রিকল, এদিকে ওই যে ব্র্যাকিওসেফালিক ভেন, সুপিরিয়র ভেনা কেভা, রাইট অ্যাট্রিয়াম, ইনফিরিয়র ভেনা কেভা। ওকে, বাকি তো সেম, এগুলো হচ্ছে অস্পিতে আসবে, থিওরিতেও আসতে পারে।